Welcome to the second part of this lecture that will discuss the clinical management of children with plagiocephaly. The learning objectives for this content were covered in the first aspect of this lecture on torticollis, so I won't reiterate those here, but we'll be moving through that general organization of the elements of PT practice, starting with examination and moving through intervention. Although we will discuss some of the background of plagiocephaly in the causes of plagiocephaly, it's not the intention here to reiterate the information that you have from your clinical medicine notes. So you'll need to pull that information forward to really have a nice, well-rounded picture of the child with plagiocephaly. You'll see in the literature that there are a variety of names for plagiocephaly. For purposes of this lecture, we're going to stick with the term plagiocephaly or cranial deformation to refer to the misshapen skull. You will see some other terms such as deformational plagiocephaly or positional plagiocephaly that somewhat tease out when the plagiocephaly developed, but for our purposes, we'll stick with plagiocephaly as our primary term with some usage of cranial deformation. Essentially, the skull is misshapen due to some sort of mechanical forces that occur, and that can happen either prenatally or postnatally. We're going to spend this lecture talking about the postnatal causes of plagiocephaly and subsequently how the physical therapist will intervene at this postnatally period of time. This slide demonstrates through pictures why plagiocephaly is such a challenge and so prevalent in infants today. Essentially, children are spending too much time with pressure on the back of their skull. So too much time in the supine or semi-reclined position, and that's for two primary reasons. One is related to the Back to Sleep campaign and SIDS, and the other is related to time spent in positioning devices. So if you look at the graph on the left, the Back to Sleep campaign began in 1992 in an effort to reduce the risk of sudden infant death syndrome. So you can see that in the yellow there, the rate of sudden infant death syndrome went down drastically. So there was a 40% reduction very early on in the rate of SIDS. So in essence, this campaign was extremely effective for decreasing the amount of infants who were passing away from SIDS. And you can see there with the purple that as the percentage of children who slept on their back got higher, the incidence of SIDS went lower. So it was certainly an effective campaign for that. However, having the patient or having the child sleep in the supine position increased the amount of time quite a bit that the pressure was on the back of their head. So the incidence of plagiocephaly really went through the roof as soon as the campaign for SIDS began and most children then started to transition over to sleeping on their back. The second area that challenges this and that further contributes to this problem is positioning of children when they're not sleeping. So oftentimes children are set in containers, and we talked about this in the torticollis lecture, where they're not free to move and explore their environment, and they end up putting even more pressure on the base of their skull. This is also linked to the development of torticollis, which is why plagiocephaly and torticollis are so commonly seen together. So thinking about the amount of time that the child spends either on a floor mat in supine, in a car seat, in a swing, or in a crib, if you were to add up all those hours over the course of a 24-hour period of time, depending on the infant and their situation with their caregivers, it could be a fair amount of time. So we kind of have a perfect storm for plagiocephaly to develop on a skull that's very malleable early on and really can't withstand the amount of stress that is placed on the posterior aspect of the skull. The larger category of cranial deformation is subdivided into further categories and named based on the location of the flattening. So we'll take a moment and go through these images here below. On the left is the shape of a typically developing skull that has not had any excess external pressure on the skull to deform it in any way. If we slide over, plagiocephaly then is identified as having a head shape that is similar to a parallelogram. So you will have ipsilateral occipital flattening, which I've shown there with the red line, and then contralateral occipital bossing, and that's a term for bulging, on that side where I've demonstrated with the green line. For children, usually the right occipital flattening is much more common than the left. And also, usually, when you have occipital flattening and it's combined with torticollis, the torticollis is usually on the opposite side of the flattening. So for example, in this picture, this child has right occipital flattening, which would mean that their left sternocleidomastoid muscle is the involved muscle and that has the tightness as it relates to torticollis. Continuing to slide over to the right of these pictures, you have the child who has more of that central occipital flattening, so not really on one side more than the other, and that's due to prolonged positioning in supine. That's termed brachiocephaly, and you can see that listed there with that hot pink line showing that flattening going straight across the back of the skull. Moving over one more, we have scaphocephaly, and by definition, that is a child who has a more long and narrow skull, and that could be due to prematurity or through delivery that took quite a long time in the vaginal canal. So several different reasons why that can occur. We're going to focus the majority of this lecture on the child with plagiocephaly. It's important to remember that with any deformation of the skull, the bones, because they are so malleable, are really just adapting to whatever external force is applied to them over a prolonged period of time. So those bones will adapt to that force, and if there is an area that is flattening, then there needs to be an area that is bulging, or what we would term bossing, to make up for that flattened area, because that has to go somewhere as the bones are still molding and reshaping. So these are two opposite presentations, but both are plagiocephaly. On the left, we have the right occipital flattening, which then leads to the right ear being displaced anteriorly with right-sided ipsilateral frontal bossing and left-sided contralateral occipital bossing. That's in contrast to the picture over on the right, where you have the left occipital flattening, and therefore the left ear is shifted anteriorly, and then you can see the bossing up there on the left anterior aspect in the front, and also bossing on the right posterior occipital region as well. Both plagiocephaly, just backwards presentations. Thus far in this lecture, we've really only spoken about the cranial deformation as it relates to plagiocephaly. So you might be asking yourself, is this something that a physical therapist really should be involved in addressing? Is this more of a cosmetic concern, or are there other challenges that can happen associated with plagiocephaly? And the evidence now that we have really does suggest that there are concerns in other domains with plagiocephaly, and physical therapists should be one of the primary members of the team to help address this issue with the child and family. So certainly there is a cosmetic consideration, but it goes much beyond that. There has been research to demonstrate that speech delays and special education requirements were greater in children who had plagiocephaly, especially with a left-sided involvement, as compared to their age-matched peers without plagiocephaly. Additionally, the children with plagiocephaly were more likely to require related services in their school-aged years. So there certainly is additional concern just beyond the cosmesis. From a motor perspective, evidence has demonstrated that there will be motor delays when the child is younger on, so between that 2-year-old and 4-year-old age range, as compared to children without plagiocephaly. So not developing as expected and having delays in balance and postural control in that younger toddler preschool age population. Additionally, there's also evidence to support that vision is a problem with these children, which makes sense when we think about some more severe forms of plagiocephaly where the occipital orbit might be also malaligned due to the positioning. And then neuropsychiatric disorders such as ADHD and subsequent challenges with social interaction has also been demonstrated to be more likely to occur in children who have plagiocephaly. So there certainly is evidence that suggests that plagiocephaly has far-reaching impact beyond just the cosmetic aspect. The management for a child with plagiocephaly can and should begin very early, as we discussed for the child with torticollis. Thinking back to that lecture, you'll recall that we talked about early screening, education to healthcare professionals and parents and families, as well as early referral in the management of torticollis. Those same clinical practice guidelines could be extrapolated to the management of plagiocephaly, as we know that children with torticollis often have plagiocephaly as a co-occurring condition. When thinking about beginning an examination, you know we're going to start with that child's observation of function. So we want to observe them participating in their everyday activities and performing a variety of activities so we can really determine what their participation restrictions are as well as their activity limitations. Taking the subjective history from the parent for the child with plagiocephaly is really not that different as what we spoke about in torticollis, so you can refer back to that aspect of your lecture. Certainly you want to be sure that you include all of the important questions that we've talked about previously this semester. What is the child's typical day? Any important past medical or surgical history and any medications. That's going to give you a really well-rounded view of that child from a subjective perspective. It's also going to clue us in on areas that we can provide patient education on as it relates to positioning and getting the child out of any sort of container device in on prone, but that would happen later as we move into intervention. From there, you're going to complete a systems review, and again, thinking about all potential coexisting conditions or involved systems such as the musculoskeletal, neuromuscular, cardiopulmonary, integumentary, as well as other systems such as vision or hearing. Then you'll select your specific tests and measures. We'll talk about observation in a bit on the next slide, but we will also discuss other ways to measure specifically for plagiocephaly as it relates to anthropometric, photographic, and other imaging that can be conducted. As we look to gather objective information during our examination, we're going to begin with observation. There is quite a bit of information that one can gather just by observing the position of the head and by palpating for sutures. You're going to want to examine the head from a variety of planes. So thinking about looking down at the child's head, so examining from superior views, anterior and posterior views, as well as lateral views on both the left and the right. We previously talked about plagiocephaly resembling a parallelogram, and you can see that again in the picture over to the upper right-hand corner. You want to be able to use your palpation skills to be able to palpate over where the sutures are approximately located, as you shouldn't really be feeling any sutures on palpation or be able to see any ridges that have been formed. Plagiocephaly, again, will have that unilateral occipital flattening as well as contralateral occipital bossing. we would expect that ipsilateral ear to be anterior. And one way that you can look for that, that's a pretty simple test, is to place your fingers under the child's ear and then look down at your fingers to see if one finger has shifted anteriorly as compared to the other. Similarly, you can look for bossing by using your fingers over the child's eyebrow to see if one of your fingers is sticking further anteriorly than the other when the therapist is positioned behind the child. Later on in the lecture, we'll talk about how you use this information that you gathered from your observation to use one or a few classification scales and systems which can help you document and also determine the severity of the plagiocephaly. Anthropometric measurements are going to be a vital part of any examination for a child with plagiocephaly. We're going to first start with a discussion on 3 traditional measurements that are pretty efficient and easy to be done in the clinic based on the examiner's experience and level of comfort with these tools, and they're also low cost. These are quick measurements typically that could be reproduced at different intervals over intervention to be able to track the child's progression. We'll talk about sliding calipers, thermoplastic measurements, and flexi-curves. In the upper left-hand corner, you'll see a picture of the sliding calipers and a picture of the child being measured with the sliding calipers. So the data that you're gathering when using the calipers relates to the width and length of the child's head as well as the oblique distances. You're also going to want to calculate the circumference when using these. These measurements are going to allow you to diagnose and classify, and then being able to monitor either plagiocephaly or brachiocephaly. You'll take those measurements and you'll compare them to the age-matched norms for that particular child. Over to the right-hand side of the slide is the flexicurve, which is really like a flexible ruler. You're going to take the flexicurve and you're going to place it around the child's head in a vertical orientation, as you can see on the left aspect of that picture there. From there, you're going to take a pen and lightly mark 2 points on the flexicurve, which you can see in red arrows there. You're going to mark where on the flexicurve is in line with the child's bridge of their nose, and then in the posterior aspect where the midline of the occiput is located. So you'll just make those marks right on the flexicurve. After that, you're going to take that off and place it on a cranial vault asymmetry paper. So you don't need this paper, but that's what's shown over there on the right-hand side. And from there, you're going to trace the circumference of the head and then the midpoint of the head, and then draw 2 diagonals, which we'll talk about on the next slide, which is going to help you calculate your cranial vault asymmetry index. At the bottom of the slide, this shows us a thermoplastic strategy where you take a strip of thermoplastic material and you position it around the child's head, and within a couple minutes that material will harden and you will then have landmarks similar to what we previously discussed with the flexicurve that you can then draw out and examine your diagonals and calculate the cranial vault asymmetry index as well as the cranial index. Although for our purposes in this course, you're not going to be asked to calculate the cranial vault asymmetry index, it is a good idea to have an awareness of how you could go about calculating this when looking to examine children with plagiocephaly, and then using that information moving forward to make recommendations for intervention based on level of severity. So you can gather the data from any of the measurements we've previously talked about, the flexicurve, the thermoplastic strategy, the calipers, or even CT scans. And we've already talked through how you're going to calculate your lines going down the middle, so that vertical and that horizontal line that are going to cross. From there, you're going to measure in millimeters at a 30-degree angle from the center of the nose to the outer ridge of the eyebrows. And then you're going to draw your lines through the center of those lines. Those will give you the diagonals necessary to use the formula here, which is the longer diagonal minus the shorter diagonal divided by the longer diagonal and times by 100. The calculated results from the CVAI can help gauge the level of involvement of that child. You can see in the list below, a 0% is perfect symmetry. Anywhere from 0 to 3.5% would still be considered within normal limits and likely would not require any intervention at all. When you get between 3.5% to a bit over 6%, that's more of a minimal asymmetry. Around 6 to close to 9 is a moderate asymmetry. And then 9 to 11 is a more severe asymmetry where you start to have more of a moderate ear shift and more anterior involvement relative to asymmetry of the orbit. Beyond 11 is quite severe, where we really see more severe ear shift and both orbital and cheek asymmetry. We'll talk a bit later in the lecture when we think about intervention recommendations and prognosticating the level of improvement for these children as it relates to this data here. There's also a formula to calculate level of involvement and severity for children with brachycephaly called the cranial index, and also referred to as the cephalic ratio. Again, you're not going to be responsible for actually calculating this information, but it's good to have an idea relative to the different levels of severity and what recommendations you might make based off of this data. So the cephalic index is basically the width of the head divided by the length in times 100. So you can see the scale over there to the right, and these values will vary based on which body of evidence you read. But generally speaking, a mild brachycephaly is anywhere from 82 to 90%. Between 90 and 100 is more of a moderate, and anything above 100 would be a severe brachycephaly. So you can envision that when the length of the head is equal to the width of the head, that would be a large surface area on the posterior aspect of that head and be considered a severe brachycephaly. Therapists are also able to use photographs as a low-tech option to be able to document the severity of the deformation as well as track progress with intervention. So with a still picture, the advantage is that your landmarks aren't wiggling around and moving as you're trying to mark them, so it may assist the therapist in improvement in accuracy, especially if inexperienced with the previous measurement tools. You can also send the child back to the physician to recommend imaging such as CT scans or ultrasound. And really, we'd think about doing that if we weren't sure that the plagiocephaly was due to pressure on the back of the skull or some atypical presentation such as synostotic plagiocephaly, which is premature closure of the sutures. That would require surgery. We'll talk about that in a bit. So anytime that the sutures have prematurely closed, that is not going to be a child who would then be a candidate for helmet therapy or cranial remolding devices, which we'll talk about momentarily. So you might choose to send the child for a CT scan, which is more the gold standard to really rule out that the child doesn't have synostotic plagiocephaly. In addition to the objective information that you would gather from your observation and your measurement of that child's skull shape, you would want to take a look at some other domains as part of your thorough examination. Many of these are the same as what you would consider examining for the child with torticollis, and some of that is due to the fact that oftentimes these two conditions occur together. You would want to take a look at visual tracking as it relates to that child, as well as motor function, posture, and balance and postural control. You could use a variety of standardized outcome measures to gauge where the child is functioning motorically based on the age of that individual at the time of the evaluation. You'll want to take a look at that infant's posture within the positions that that child most frequently occupies. So you may be doing that in a seated position or in a prone or supine position as it relates to any asymmetries. And then certainly looking at that child's balance and postural control in the developmental positions that are relevant for that individual. So it is likely that due to potential asymmetries and deviations in posture, that the child's balance and postural control is often not what we would expect for that child's typically developing age. Once you've collected any and all pertinent data, you can take that information and synthesize it to form an accurate clinical picture. Part of that picture for children with plagiocephaly is being able to classify the level of severity of the deformation. This is important as we go on to make treatment recommendations and what type of intervention would be most appropriate for this child. On this slide, there are two strategies to use to be able to do that. The first is the severity assessment for plagiocephaly. So if you look to the left of your slide, you'll see the pictures that represent 5 different categories with a grading scale of 0 to 3, with 0 being no or very minimal involvement and 3 being more of a severe presentation for each of those categories. The categories are dealing with posterior flattening, ear malalignment, forehead asymmetry, neck involvement, and facial asymmetry. So the therapist would take a look at the pictures and evaluate that against the child's presentation and come up with a total score. More commonly used in the more recent literature is Argenta's classification scale, and that is a scale ranging from a score of 1 to a score of 5. Again, as the score increases, the level of severity worsens. You're not going to be responsible for being able to differentiate between all of those levels, but you should have an understanding that as the numbers increase, the severity increases. You can take a look there at classification level 1. There's only posterior asymmetry, so that would be the mildest form. And then as we move on, just looking at level 4 as an example, not only do you have posterior asymmetry, but the ear position is not in line with the other, and you have facial asymmetry that goes with it. So as you move up on that scale, the severity also increases. In addition to classifying the child based on level of severity, part of the evaluation process is examining the impact of other comorbidities on the child's presentation. Most commonly, that would be the torticollis that we've previously discussed. You're going to generate a needs and a strengths list and really think about how those underlying impairments are currently impacting that child's activity and participation level, as well as how it could go on to impact these areas of the ICF if intervention was not provided. Additionally, you'll want to consider the other comorbidities that the child may have, especially torticollis, as we know how these two conditions are closely linked, and consider how this affects the big picture as it relates to activity limitations and participation restrictions. As far as a differential diagnosis goes, we are going to be skilled in this area because we are going to use the observation that was previously discussed, as well as our palpation, to try to determine if the plagiocephaly is due to deformation because of external forces on these malleable cranium bones, or if it's due to another condition such as craniosynostosis, which is premature closing of the sutures. In order to be 100% sure that the child does not have craniosynostosis, you would need to rule that out through some type of imaging, and use of CT is the gold standard there. However, we can make a referral back to the physician based on our skilled observation and palpation skills. If you look over at the picture on the left is the same picture that you've been seeing as it relates to the child with plagiocephaly. So you know to expect ipsilateral flattening of the occiput with that ear placed anteriorly, displaced anteriorly, and then in the front you have that ipsilateral frontal bossing. If you slide over to the right, it's a bit of a different story. So when a child has premature suture closing, you can expect to see the flattening of the ipsilateral occiput as we saw before, but the ear is now displaced posteriorly on that side and anterior on the contralateral side. So that's a difference. And then additionally, you would expect to see frontal bossing on the contralateral side. So those are differences and might help to clue us in that this is not just a straight up plagiocephaly based on external forces being applied to the cranium. This is not a very common condition. The prevalence of this, or the incidence of this, is 1 in 200 or in 2,500. And I've only seen this probably twice in my 23 plus clinical years of experience, but it is really important to rule this out, because if you go on to put a helmet on a child with craniosynostosis, that would be extremely harmful to the internal structures of the brain. So you're going to want to rule that out. You could also use palpation skills to assist you in this, because children with craniosynostosis, you might actually be able to palpate a bony ridge where those sutures have prematurely closed. So you really should not feel anything over where you know the sutures to be. The prognosis for children with plagiocephaly is based on severity, the age of the child at which they begin treatment, and the selected intervention. From a severity perspective, if you think back to the classification scales, the Argenta scale that we talked about, as well as some of the cranial vault asymmetry indexes, you can imagine that as the severity is worsened, that you're going to need a longer episode of care, and that it's likely that the child will not receive complete resolution. Additionally, any treatment, regardless of if it's positioning and patient education, or if it's helmet therapy, which is also called cranial remolding devices, if it's initiated after that 6 to 7 month of age, when the sutures have already begun to close a bit, those children are going to have poorer outcomes to really achieve that complete resolution, as compared if you would have started much earlier. And then prognosticating who is going to need a helmet and who isn't, we'll get to that in a few slides, but somebody who has a greater severity is really going to need that helmet for more resolution and a lessened episode of care. Next, we'll talk about physical therapy intervention for the child with plagiocephaly. Intervention is focused on 3 primary areas: positioning, helmet therapy, and caregiver education. Positioning and caregiver education is very similar to what we've already discussed for the child with torticollis, so we won't spend quite as much time in those areas. Plagiocephaly, however, often requires use of a helmet or a cranial remolding device to be able to get full resolution, especially for those children who have a more severe case or who don't respond to traditional repositioning and education. Regardless if intervention is preventative in nature through that early screening process, or if it's in response to a current plagiocephaly, the primary premise behind this is to keep the pressure off the back of the head. So you would do that by a variety of positions through use of prone play, positioning, encouraging the development of that child's head control, and then really only providing time and containers that's purposeful. So engaging the child in some sort of other activity where they're still getting that active movement so that they're not just directly putting pressure on the posterior aspect of their skull. You want to use those containers in moderation, as we've talked about before, and really promoting free movement within the environment. So there's a time and a place for children to be in a variety of different types of equipment or containers, but really looking to encourage much more active and free movement across their environment. There are some really nice alternative positioning devices that could be considered for patients with plagiocephaly that would help relieve the pressure off the posterior aspect of their skull. The picture on the upper left-hand corner is the bumbo chair. So this is a foam that is almost like a bucket. It's a scoop bucket of sorts, and it kind of snugs the baby up in the back and on the sides. You can also put additional towels in the seat itself if the child needs additional trunk support. But the nice thing about the bumbo chair is that it can be used at fairly young ages, maybe about 3 or 4 months of age, depending on that child's level of head control. And they don't really have to be able to sit independently. The up seat is the picture on the right, and that is the more advanced version of the bumbo chair. So this is newer, and it places the child in a bit of an anterior pelvic tilt, as you can see there up on the picture. So this promotes spinal extension and head extension as well, but the same concept as the bumbo seat. If we move down below, the lower picture to the left-hand corner is called the Bobby Noggin head support. And this is made of memory foam, and the purpose of it is to relieve the pressure against the posterior aspect of the skull. So this could be used in a child's car seat or in a swing, but you just want to make sure that it is removed if the child is going to fall asleep, because you don't want to cause any approximation with the airway that could challenge that individual while they're sleeping and breathing. On the right-hand side is what is called a chortle. So this is a cap that goes on the child's head, and there is a little mohawk or tail of sorts that you can alternate to either side. And this helps provide a passive stretch on the baby's head, so it can be used in combination with torticollis as well. And it really is there to help prevent plagiocephaly from happening. So when the mohawk is over, as it is in this picture, to the left of this child, it really limits their ability from rotating left when they're in the supine position. And then you would switch that back and forth. So they never really get to develop pressure on any one side. Again, this would not be a device that you would have on the child when they're napping or going to sleep for the evening. Just a few quick comments here on positioning, because we already covered this in the torticollis lecture, but the research is conclusive that preventative positioning with physical therapy will significantly reduce the likelihood of the infant developing plagiocephaly. So you want to be able to provide that education to the caregiver very early on as it relates to sleeping. So you can see the picture to the right, which comes from the Pathways organization for parents, that you want to alternate the position of the child in the crib so that the head points in one direction on one day and the opposite direction on the other day, and you would alternate that. That way, if they're rotating to look towards the door, they're getting that alteration between right and left sides. Same kind of process for feeding, thinking about providing food sources on alternating sides. And we've already discussed how important tummy time is to take the pressure off the posterior aspect of the skull, and really limiting the time that the child spends in the containers, especially those that put pressure on the posterior aspect of the head. Additionally, anything that the caregiver can do to make that time more active and encourage rotation of the head so that they are deviating where that pressure is occurring would be beneficial. The next aspect we'll talk about as it relates to intervention for children with plagiocephaly is the use of orthoses, such as helmets, otherwise known as cranial remolding devices. These orthoses are fabricated out of thermoplastic materials and lined with high-density foam. To cast an infant for a helmet, you can either use plaster, which is a bit of a more historical approach and is a bit messier, or a 3D laser image to gain all of the measurements you need for that child's head in order to cast the appropriate helmet with the appropriate cutouts. Use of helmets for children with plagiocephaly can be quite effective, and often results might be quicker than traditional repositioning therapy. Helmets work by allowing growth in the flattened areas and redirecting growth in other areas so that you're really promoting symmetry of the skull. So if you look at the picture there, you can see that the helmet is fitting pretty snug in the locations of the bossed areas, or those areas that are bulging, and then there's space there where the flattened areas are located. So this is going to limit any additional growth in the bossing area and is really redirecting that growth towards the flattened area. Another way to think of this is that any place in which the skull approximates the helmet, such as the bossed areas, the helmet itself is going to obstruct further growth of the cranium. Where there's an opening, that is where the cranium is going to fill in and grow within the limits of that container or helmet. There are a variety of factors that go into the clinical decision-making process related to recommending a helmet for a child with plagiocephaly. You should not be thinking about recommending a helmet for a child unless they have pretty decent head control across the developmental positions that they are in. So that could be from pull to sit or in a sitting position. They should have pretty good head control because the helmet itself is going to add just a little bit of weight to that child's head, and they'll need to be able to control that. So taking a look at what the head control of the child is like and then making a decision from there. Helmets are also most effective in periods of rapid growth. So really thinking if you want to mold the cranial bones, you want to take advantage of when they are rapidly growing, and that is usually right around that age 4 months. So between 4 and 7 months is the most ideal time to put a helmet on a child, usually closer to that 4 months. You also need to consider the severity of the plagiocephaly when making this recommendation and when you're going to make this recommendation. So children with a more mild presentation of plagiocephaly, you're probably not going to go straight to the helmet. You're going to try the parent education and the repositioning first. For a child who has a more severe presentation, then you might try repositioning and helmet therapy concurrently. And then if you have a really severe presentation, you might just go straight to the helmet therapy and then initiate some of those other pieces after. So if we think back to that CVAI, that index that we previously talked about, we had said that between around 6 and 8 was more of a moderate asymmetry. That would be an appropriate time to recommend a helmet. If a child has a severity that places them between 6 and 8% on that cranial vol asymmetry index, then you should be thinking about making those recommendations for a helmet in conjunction with the repositioning. CVAI values of 9 or greater, typically you're going to go straight to the helmet. So that is somewhat of a guiding factor when thinking about making this recommendation. Additionally, thinking about that Argenta classification scale, we usually think of levels 3, 4, and 5 as benefiting from the helmet. So you would go ahead and make that recommendation as well. Some evidence suggests that if you don't get the helmet on by 12 months of age, that it's not really going to do the child any good to initiate it at that point. But there is a body of evidence that suggests you can get some correction even up through 18 months of age. The other factor involved in the recommendation for helmet therapy is the family's willingness to comply with the treatment program. So these helmets need to be worn 23 hours a day and really only removed for hygiene-related issues, so bath time and to give the child just a brief break from that orthoses. You need to build up the wearing time slowly, as you would with any orthotic device, and perform routine skin checks to make sure that the child is tolerating the helmet okay and that you're not getting any areas of redness that last longer than 15 minutes or so, because we need to be really mindful that the child's skin could break down, and we certainly want to avoid that. The child will need to be recasted likely depending on how long they use the helmet for. So usually a child goes through at least one recasting of a helmet throughout the duration of this helmet therapy. The overall duration itself, how long the child needs to wear the helmet for, will vary based on the severity of the presentation and when this helmet therapy was initiated. So children might wear this helmet anywhere from 3 months to 6 months based on those factors. And then there are some other considerations before you recommend the helmet. So the cost of the helmet. Usually insurance is more likely to cover a helmet with a younger child, so that 4, 5, 6 months of age, as opposed to a child over a year, because they're aware that the resolution isn't going to be as great. And then parental concerns. So sometimes parents are very concerned with how the helmet will look on the child or how the helmet will be tolerated by the child. This is something that the parent has to be okay with in order for you to move forward. Otherwise, the compliance for the helmet use is probably going to be pretty low, and then you're not going to get the desired outcome. It's my clinical experience that babies usually tolerate this helmet very well, especially if it's put on under the age of 6 months. They may fuss for that first day or so, but then it's like there's nothing on them. So they do tolerate it very well, and usually the parents end up being worried and it doesn't come to fruition because the tolerance is usually pretty good. This slide contains a variety of pictures of before and after helmet use for children of different ages and different severity levels. I can tell you from clinical experience that using the helmet usually causes drastic changes in the shape of the skull, especially if used during that 4 to 7 month period of time. Again, variables that impact how much the child resolves is based on the age at which they begin and the severity of the shape of the skull. So you can see a few pictures here. Most of them are more of a moderate to severe presentation, but even so, getting some really nice resolution after use of the helmet. And of course, we know that any intervention needs to include caregiver education, and this is especially true for patients with plagiocephaly and torticollis, as we've already discussed. So really no different than thinking about approaching the management of children with torticollis. Plagiocephaly is that same premise. Ideally, we would like to talk to these parents and medical practitioners while the child is in the hospital before discharge, because we can prevent a lot of this. If this is a result of post-uteral deformation, we can really prevent and reduce the likelihood of this happening through prone positioning, promoting active exploration of the environment, moderating time spent in containers, and really using that in a purposeful way. We know from research that we can really prevent a lot of plagiocephaly from even happening in the first place, or it's a much less severe form. And then you want to continue the education even during treatment on all of those aspects: the prone positioning, exploration of the environment, and modification of sleeping positions and whatnot. And then certainly how you set the environment up as it relates to toys and food sources, all of those same concepts that we spoke about in torticollis are important and relevant here for plagiocephaly. There are several variables that a physical therapist must evaluate when thinking about discontinuing a child from PT services. For a child with plagiocephaly, those criteria or guiding factors are quite similar to what we talked about with torticollis. You're looking for passive range of motion to be primarily full and equal to both sides, and that the child has symmetrical movement between their right and left sides. Certainly, we're looking for them to have age-appropriate motor skills, and a child with plagiocephaly really shouldn't be beyond the Argentina classification scale of type 1, or you're referring them back to the physician. And certainly we're looking for the parent to have developed skill to effectively carry over the positioning and other required programs, perhaps stretching for this child before thinking about discontinuing them. Something to keep in mind is that the bone in this case supersedes the muscle. So if you have a child who has both plagiocephaly and torticollis, we're really much more concerned about getting intervention geared towards the plagiocephaly because we know we have a limited amount of time. So if a child is going to use a helmet, knowing that the bones are going to be pretty much completely sutured by 18 months of age, we need to get that helmet on early. So a lot of the focus then should be about repositioning, taking the pressure off the posterior aspect of the skull, but also initiating the helmet if it's warranted. We can always go back and really target and focus on the stretching aspect for the sternocleidomastoid and all of those aspects later on, but we really have to be pretty aggressive when we're dealing with the cranial bones because we only have a limited amount of time. Similar to the patient with torticollis, it might be beneficial to keep them on a consultation level just to make sure that they continue to develop in an age-appropriate manner and that there isn't any other concerns that arise during that time. So usually we ask them to get back in contact with the physical therapist or at least check in with the physician related specifically to the plagiocephaly approximately 1 year after discontinuation.